So good morning again. We're going to do cardiomyopathies this morning. And when we talk about cardiomyopathies, it's heart muscle disease. So heart muscle disease, you could have so if we have uh, decreased blood flow to the heart muscle because of blockage, we call that ischemic cardiomyopathy. If you have high blood pressure, hypertension, which cause thickening of the heart muscle. We call that hypertensive cardiomyopathy. And then you can have thickening of the heart muscle for whatever reason. We call that uh, hypertrophic cardiomyopathy. And then, if the heart muscle is weakened, um, we have a number of names for that. One of them is a dilated cardiomyopathy. So any heart muscle pathology, any heart muscle disease, that's what we call a cardiomyopathy. So we're going to define what cardiomyopathies are, some of the signs and symptoms related to cardiomyopathies, how we classify them, the causes, and then the echo features. Um, okay. So again, when we say cardiomyopathies, it's a deterioration of the heart muscle function, a deterioration of the myocardial function. Okay, and that usually leads to what we call heart failure. It will lead to heart failure, and then the signs and symptoms of heart failure, dyspnea, which means shortness of breath. It usually starts with shortness of breath with exertion, and then it goes on to shortness of breath as it progresses, shortness of breath at rest. Peripheral edema, which means when you check the legs are swollen with fluid. And, you can have swelling at the sacral region, just at the buttocks if the patient is lying down. Uh, you know, you can have what we call ascites. Those are some of the features of heart failure. Arrhythmia, which is abnormal rhythm, you can also get that from the cardiomyopathy. And then sudden cardiac death. Sudden cardiac death is usually related to arrhythmia, usually ventricular tachycardia, ventricular fibrillation. So this is how we're going to classify cardiomyopathies here today. Dilated cardiomyopathy, which means the heart muscle is weakened and the chambers are dilated. And then hypertrophic cardiomyopathy where the heart muscle is thickened. Usually we don't know why it thickens. It's probably a genetic problem. And then restrictive cardiomyopathy where there's some infiltration in the heart muscle and it becomes stiff. And then another common cardiomyopathy we call arrhythmogenic right ventricular cardiomyopathy, where the right ventricle, the right side of the heart, is infiltrated by fibrofatty tissue. And as you know, fat does not contract, so you're going to lose your heart muscle function on the right side. And those patients tend to develop arrhythmia, ventricular tachycardia, ventricular fibrillation. And then we're going to round out everything with what we call non-compaction of the left ventricular myocardium. That is where the myocardium looks it is very spongy, and there's a lot of trabeculation in the myocardium. And you'll have the left ventricular systolic function will be depressed. All right, so when we say a dilated cardiomyopathy, all the chambers are enlarged, or just the left ventricle, the left atrium is enlarged, and then you have the ejection fraction is reduced. So, you have seen those cases of dilated cardiomyopathy. Um, Again, the left ventricle is dilated and the ejection fraction is reduced. Um, there's something we call the sphericity index. So And the definition of this first, the index, is you do the LV long axis dimension, and you put it over the short axis dimension, and the normal is usually greater than 1.5. So in the short axis, we do the long axis dimension, and we put it over the short axis dimension, and it's usually greater than 1.5, sorry. And then you can also measure the LV mass, okay? If in someone with a dilated cardiomyopathy, LV mass is going to go up, it's going to increase. So again, some of the causes for a dilated cardiomyopathy is myocardial infarction or ischemia. So when you have say a myocardial infarction, the heart muscle dies. The heart muscle dies and it's stretched. That phenomenon is called is something we call remodeling. When the heart muscle dies, it becomes thin and dilated. We call that remodeling. So as a result of that, the heart muscle, the LV chambers, the chambers in the heart dilate, and the heart muscle, the ejection fraction is reduced. The same thing occurs when you have ischemia. Ischemia is decreased blood flow to the heart muscle. So if the heart muscle is not getting sufficient blood, it's gonna thin and it's gonna dilate. Okay, myocardial infarction or ischemia. And then myocarditis. That's when you see myocarditis, it means inflammation of the heart muscle. And you can get inflammation of the heart muscle from infection, Coxsackie B virus or enterovirus. So a viral infection can affect the heart muscle, and it can get thin, and it can dilate, and then the chambers will be dilated. The ejection fraction will be reduced, and the patient can develop a dilated cardiomyopathy. Alcoholic cardiomyopathy. So a lot of our patients drink excessive amount of alcohol, and alcohol is one of the more common agents that can weaken the heart muscle. We see a lot of patients with alcoholic cardiomyopathy. Okay, they drink excessive amount of alcohol, and it weakens the heart muscle, and the chambers are dilated. Hemochromatosis, that means a iron overload. So if there is iron overload in the body, one of the organs that the iron tend to accumulate in is the heart. So it accumulates in the heart muscle, and it weakens the heart muscle, and the heart muscle can dilate. Peripartum cardiomyopathy. So when you say peripartum, it means, in pregnancy. So it's usually, peripartum means close to the time of delivery. So we will see a peripartum cardiomyopathy sometimes a few weeks before delivery, or a few weeks after the mother delivered the baby. So just around the time of delivery, that's the time you're going to see a peripartum cardiomyopathy. And the thing about it, pregnancy sometimes can give the patient shortness of breath and swelling of the legs. So sometimes it's difficult to diagnose a peripartum cardiomyopathy as opposed to just a normal pregnancy. So that's when an echo is very, very important, because some of the features of a normal pregnancy, shortness of breath and leg swelling. But if it's more excessive than what you would get in a normal pregnancy, you have to evaluate the patient a little bit more, and you have to do your echo. Sarcoidosis is a connective tissue disorder, and it can affect the heart, and you can get a dilated cardiomyopathy as well. Other things such as AIDS, acquired immunodeficiency syndrome. So AIDS can weaken the heart muscle and give you a dilated cardiomyopathy. And then agents, chemotherapy that we use to treat different type of cancer. Breast cancer is a very common one. So some of the agents that you use to treat breast cancer can weaken the heart muscle. So that is why before a patient uh, get chemotherapy for, say, breast cancer, you should get a baseline echo. And then during the therapy, during the treatment, you should also get another echo, because some of these agents, especially doxorubicin and adriamycin and cobalt, can weaken the heart muscle. And you need to know this, because you don't want to treat the breast cancer, give the patient a cardiomyopathy, and then the patient dies from the cardiomyopathy. Okay? Also, you can get what we call a tachycardia-induced cardiomyopathy, and a very common tachycardia that can give rise to a cardiomyopathy is atrial fibrillation. So if the patient have atrial fibrillation for a long period of time and it's not recognized, later the patient will develop a cardiomyopathy, then they come to you with an ejection fraction of 20%. Now they're in heart failure. So it's important to recognize these patients, treat them appropriately, and prevent the development of a dilated cardiomyopathy. Frequent premature beats can also, PVCs, frequent PVCs can also give you a cardiomyopathy. In South America, we talk about Chagas disease. It is caused by the parasite Trypanosoma cruzi. So patients coming from South America who have a dilated heart and is in heart failure, this is a very common cause, Trypanosoma cruzi. Also, thyrotoxicosis, overactive thyroid. If unrecognized, it can also give a dilated cardiomyopathy. So these are some of the more common causes. So when you look at your echo, on top you have your two-dimensional echo, parasternal long axis view, and below you have your M mode view. You can, if you do your measurements and stuff, you'll see that the chambers are dilated when you do your measurements. And not only that, but you can, just looking at this, in systole, the posterior wall and the septum supposed to come in to meet each other, suggesting that you have good contractility. You see, they're not, it's like you have straight lines. They're not, there's no, it's not contracting properly. So this is a reduced ejection fraction. So looking at your M mode, you can quickly make your diagnosis of a dilated cardiomyopathy. We usually talk about a reduced ejection fraction. And when we talk about a reduced ejection fraction, we talk about EF less than about 40%. Okay? And then when you look at your chambers will be dilated. Left ventricle, left atrium, sometimes the right atrium and the right ventricle. So you have to do your measurements to determine if the chambers are dilated. And then your mitral annulus will also be dilated. And because if you dilate the mitral annulus, then the mitral valve will not co-opt properly and you'll get some amount of mitral regurgitation. And if the ejection fraction is pretty low, you can get apical thrombus. So you have to look for these apical thrombus. Okay, so parasternal long axis view, you measure your left atrium and you see the left atrium is dilated. In this scenario is 6.26, which is very large. Okay, and this is your short axis. Okay, when we were talking about the sphericity index, this is what we mean. So you get your short axis and you measure the long axis like this, and then the short axis is like that. Okay, so if the length, so it's the internal diameter. Notice went straight down, but it's the internal diameter. So if from the anterior wall to inferior wall, if the length of that is called that L, and then from the septum to the lateral wall, if you call that D, then the sphericity index is equal to L over D. Okay? is first the index. And this is supposed to be greater than 1.5. What we're saying is that this measurement is supposed to be much greater than, so from the anterior wall to the inferior wall is supposed to be much greater than from the septum to the lateral wall. So, but once, when you have a dilated cardiomyopathy, then this, the dimension D, which is from the septum to the lateral wall, gets larger. So this first, the index, it becomes less than 1.5. It approaches 1. Okay? Okay, so that's what we call this first, the index. Okay. All right. But the important thing is that the chambers are dilated, and you can see that. In your measurements, you will see that. All right. And when you look at your apical four-chamber view, again, you'll see that the chambers are dilated, and you have to look for apical thrombus. The thrombus, a blood clot, is going to be in the apex. Remember that these clots can break off and travel and give you a stroke. So you have to look for blood clot in the apex. And that's because the ejection fraction is very low. And because the walls are not moving properly, blood can clot there. When you have the dilated cardiomyopathy, the mitral annulus is stretched, so the valves don't close properly and you develop mitral regurgitation. All right, so again, you can calculate cardiac output. Okay, remember, you in the apical 5-chamber view, you do your LVOT, TVI. In the parasternal long axis view, you do your diameter. So to get your cardiac output is 0.785 times D squared times the LVOT TVI. Okay, and you'll get your cardiac output. So the cardiac output is going to be low in someone who have a dilated cardiomyopathy, and that is why you should do it. When you do your pulmonary artery pressures, you might get elevated pulmonary pressures, and that is because the LV is not contracting properly, and the pressure is going to increase, and the pressure is going to go all the way back to the pulmonary system. So when you do your pulmonary pressures will be elevated. One of the things that we can, one of the features of a dilated cardiomyopathy, we say when you have dilated cardiomyopathy, you're going to have heart failure. And once the heart fails, the left ventricular end diastolic pressure is going to be elevated. The pressures in the left ventricle is going to be elevated. And later on, the pressure in the left atrium is also going to be elevated. So you can look at your mitral inflow and look at LV filling pressures. Remember, what we said is that if your EE prime is greater than 15, it suggests elevated LV filling pressures. So it is very important for us to evaluate these patients with dilated cardiomyopathy to see what the LV filling pressure is. Remember, once your LV systolic function is depressed, once you have heart failure, you're going to have some amount of diastolic dysfunction, but you just have to grade it. And you need your EE prime to grade your diastolic dysfunction. Your EE prime also, if it's greater than 15, medial, if it's greater than 15, it tells you that the LV filling pressure is elevated. Okay. Again, once you have a dilated cardiomyopathy and heart failure, your E prime is going to be reduced. Also your S prime. So both your E prime and S prime is going to be reduced when you look at your tissue Doppler imaging. And the shorter the deceleration time and the higher the EE prime, the worse the prognosis. So patients that are going to do very, very poorly, they have a very short deceleration time and a very high EE prime ratio. Very important. Again, as we said, when you have a dilated cardiomyopathy, the mitral annulus is stretched, the mitral valves do not co-op properly, and you get some amount of mitral regurgitation. All right, you're going to get some amount of mitral regurgitation. So very important. And then when you do your continuous wave Doppler, you can quantify your mitral regurgitation. When you look at your EE prime, okay, if your EE prime is going to help you to grade the amount of diastolic dysfunction. If you just look in here, you can see that your E to A ratio is greater than 2. So this patient more than likely have a restrictive physiology, okay, or what we call a grade 3 diastolic dysfunction. Grade 3 diastolic dysfunction tell you that the patient is very, very bad, very, very poor, okay, by looking at your E to A ratio. E to A ratio greater than 2 tell you that it's grade 3 diastolic dysfunction or the patient have a restrictive physiology. So the problem is no longer that you have abnormal relaxation. What's happening now, the heart muscle is stiff. It is stiff. All right. And then when you look at your pulmonary vein flow, you will see a blunted systolic response. Systolic component is going to be less than your diastolic component. It also helps you to grade your diastolic dysfunction. But these patients tend to have a lower systolic component than diastolic component pulmonary vein flow. All right, so we're going to move on now to hypertrophic cardiomyopathy. And when we talk about hypertrophic cardiomyopathy, you have to rule out other causes for the hypertrophy. So you have to, if the patient does not have hypertension, if the patient does not have aortic stenosis, and they come to you in the echo lab and you find the heart muscle is very thickened, then that's what we call a hypertrophic cardiomyopathy, or HCM. It's a primary disease of the heart muscle. So it's something that just develops in the heart muscle, usually from a genetic standpoint. So primary disease of the heart muscles. When we say primary, it means that it developed right in the heart muscle. It is not as a result of, say, aortic stenosis or hypertension. So it's a primary disease of the heart muscle in which portion of the heart muscle is thickened, hypertrophed. It's thickened. You have to rule out other causes. If it's hypertensive, if it's hypertension that causes a thickening, then you call that hypertensive cardiomyopathy. If it's aortic stenosis that's causing the thickening, then you say that. If there's no obvious cause, then that's what you call hypertrophic cardiomyopathy. When we do further work on these patients, we see that the sarcomeres increase in size. So the sarcomeres are a component of the heart muscles, and when we the contractile elements of the heart muscles, and we see that they're increase in size. And then also you have what we call myocardial disarray. So these are microscopic features now. You have myocardial disarray. You have disruption in the normal alignment of the heart muscles. So increase in the size of the sarcomeres, myocardial disarray, is a feature of hypertrophic cardiomyopathy. And again, as we say, it's usually a genetic problem where you have mutation in one of the 10 sarcomeric genes that results in mutated protein in the sarcomere. It is autosomal dominant, okay? And the prevalence in the population is about 0.2 to 0.5%. And there are different types of hypertrophic cardiomyopathy. We also call it HCM. You can have just the septum can be very, very thickened. We call that asymmetric septal hypertrophy. So just the septum, if it's very thickened, we call that asymmetric septal hypertrophy. It can be, the thickening can be all around, so we call that concentric hypertrophy. It can be just located in the apical portion, and we call that apical hypertrophy. Or they just in the LV free wall, we call that LV free wall hypertrophy. So let's look at the asymmetric septal hypertrophy. Just the septum is now thickened. You must have seen patients with septal bulging. Okay, some of these patients do have asymmetric septal hypertrophy. So just the septum is thickened. The anterior portion of the mitral leaflet and papillary muscles tend to be affected. So when you have asymmetrical septal hypertrophy, it's common for the papillary muscle and the anterior leaflet of the mitral valve to have an abnormal position. And because of this abnormal position or location of the papillary muscle and the anterior mitral leaflet, a lot of these patients are going to have mitral regurgitation. Okay, they're going to have also what we call SAM. So SAM is systolic anterior motion of the mitral valve. And what that is in systole, the mitral valve move towards the left ventricular flow tract. So that's SAM. Okay, in systole, the mitral valve moves anterior. So it moves into the left ventricular flow tract, and that can give rise to obstruction. It can obstruct the left ventricular flow tract. As we have mentioned above, because a lot of these patients with asymmetric septal hypertrophy, the papillary muscle and the mitral leaflet is abnormally positioned, and you'll get mitral regurgitation as a result of that. And because of this SAM, you can get left ventricular flow tract obstruction. In systole, the mitral valve moves anteriorly towards the left ventricular flow tract. All right, so when you look at the M mode of a patient with hypertrophic cardiomyopathy, so on top you have your two-dimensional echo, and then your M mode is on bottom. Once you have seen a lot of these M modes, you know that there's thickening of the RV wall. This is the RV cavity. Look at the septum. The septum is very, very thickened. Okay, you have your mitral valve right down here, and the posterior wall is thickened as well, but the septum is huge. Okay, you can just do your measurements. Each of these is 10 millimeters. So the septum is more than 20 millimeters, more than 2 centimeters. So that's very, very thickened. So, you can make your assessment. So you can see the septum is very thickened. Okay, very thickened septum. This is what we call SAM. So this is your apical 4 or 5 chamber view. But in systole, the mitral valve moves towards the left ventricular flow tract, obstructing the left ventricular flow tract. So these patients are going to develop high pressures when you do your LVOT velocity and pressures. It's going to be increased because of this systolic anterior motion of the mitral valve, SAM. This is what we call SAM. Okay, and then in systole, you're going to get turbulence across the left ventricular flow tract because, I would say, in systole, the mitral valve moves anteriorly, obstructing the left ventricular flow tract. So you're going to get turbulence there. So, you have to look for those things. All right, so again, the septum is going to be very thickened. Okay, the wall is going to be thickened, but especially the septum. Okay, so you again, SAM is when the anterior mitral, well, then the mitral valve moves anteriorly and obstruct the left ventricular flow tract. Okay. As we have said before, when you have asymmetric septal hypertrophy, the papillary muscle and the mitral valve is usually positioned abnormally, and these patients commonly have mitral regurgitation. So you have what we call anomalous insertion of the papillary muscle. It usually inserts directly into the anterior mitral leaflet, and these patients commonly have mitral regurgitation. Okay. So this is a case where you can see the septum is huge. So this is a transesophageal echo. Septum is huge. So it blocks you can see this is the left ventricular flow tract right here. It blocks it. We have a treatment where we can use alcohol, or we can just go in and shave this down. So we can do surgical procedure, open the patient chest and heart, and we just cut the muscle, cut it. So we cut it and we thin it. So you have less obstruction. You have less obstruction of the left ventricular flow tract. So myomectomy is when you cut the muscle. You cut the muscle. So this is myomectomy. This is pre-myomectomy, before you do the procedure. And this is post-myomectomy, where you shave the muscle down. So you see the muscle is thinner and you have less obstruction to the left ventricular flow tract. Okay. Now we can also use alcohol. We can use alcohol to what we call alcohol septal ablation. What we do catheterization. We locate the blood vessel that is supplying the septum, and we put alcohol in that blood vessel. So we give the patient a controlled heart attack, and by doing so, you can reduce the thickness of the septum and relieve the obstruction. So over here, this is pre-ablation, alcohol septal ablation. You can see that the mitral valve in systole, you have systolic anterior motion, blocking the left ventricular flow tract. See, the mitral valve is blocking the left ventricular flow tract. These are transesophageal echo images. And then you have a lot of turbulence in systole because you have obstruction to the left ventricular flow tract. But when you do your alcohol septal ablation, that is your catheterization, you locate the blood vessel that's supplying the septum, you inject your alcohol, you give the patient a controlled heart attack, so the muscles shrink. You can see that there's less obstruction, okay? Less obstruction to the left ventricular flow tract. And then when you do your color flow, imaging, you can see that there's almost no turbulence, suggesting that there's obstruction. So another location for your hypertrophic cardiomyopathy is the apical. So this can be located just in the apex, okay? So the thickening can be just in the apex. And we talk about the ace of spade. So this comes in all exams. So you have to know, you give contrast. So there's contrast. We inject contrast into this left ventricular cavity, and it shows the thickening in the apex. So this is your apical hypertrophy. Apical hypertrophy, okay? And it gives you the so-called ace of spade picture, okay? Apical hypertrophy. All right, so you can use your 2D echo and Doppler to look at these patients with hypertrophic cardiomyopathy. Once you do your 2D echo and you do your measurements, you're going to see that the muscles are thickened. And then you can look and find out what's the distribution of the thickening. Is it in the septal? Is it in the apical? Or it's all around? You can also get your ejection fraction by doing your echo. You can look at the RV wall to see if there's RV hypertrophy, and you can check the RV function. Remember TAPSE. Remember, you can measure the RV thickening. The best view for that is either your subcostal or your parasternal long axis view. Anything greater than 5 millimeters or 0.5 centimeters suggests you have RV hypertrophy. Or you can do your left atrial volume index. Okay, you can do the volume. And then again, with your Doppler, your tissue Doppler and stuff, you look at your LV diastolic function, you can look at your pulmonary artery systolic pressure, and you can check to see if there's LVOT dynamic obstruction. So when you go across your left ventricular flow tract and you put your PW and CW, you can see if there is obstruction. When you look at the mitral valve and your papillary muscle, you can see if you have SAM, systolic anterior motion of the mitral valve, okay, and then your transesophageal echo, you can do either surgical myomectomy or you can do alcohol septal ablation, okay? And you have to screen the first degree relatives of these patients. Screen the first degree relatives of these patients with hypertrophic cardiomyopathy because, as we mentioned before, it's a genetic, it runs in family, genetic phenomenon. So these are some of the features, if you do, so this is the mitral annulus velocity ENA, okay? Someone who have a cardiomyopathy may have a restrictive pattern. So if they have a restrictive pattern, then the E is going to be, so the E to A ratio is going to be greater than 2, or they may just have a pseudonormal pattern. So you have to do your tissue Doppler velocity to look at your E prime. And you can look at your pulmonary vein, you have systolic component, diastolic component, atrial reversal. These things will help you to grade the diastolic properties. Again, your mitral inflow, you might get this so-called L wave. So remember, when you get an L wave, it suggests you have increased left ventricular end diastolic pressure, increase left ventricular end diastolic pressure. Your E to A ratio may be greater than 2, again, suggesting that you have a restrictive physiology. The important thing is your E prime. Once a patient have a heart muscle disease, the E prime is going to be reduced. So the E prime is going to be low. Okay, we usually use the septal or the medial. Okay, so restrictive cardiomyopathy now. When we talk about restrictive cardiomyopathy, I said, there's an infiltration in the heart muscle which causes the heart muscle to be stiff or rigid. So this is what we call a restrictive cardiomyopathy, RCM. Something is infiltrating into the heart muscle and it becomes rigid or stiff. So the heart is restricted from filling with blood. Okay, so you have what we call primary causes. That is something that develops in the heart muscle itself. Or secondary, you may have some other problem which will affect the heart. Okay, for example, say for instance, the patient may have, say, they may have, say, cancer. If they have a cancer and then that cancer infiltrate the heart muscle, they may have a breast cancer and then it infiltrate the heart muscle and give you rise to a restrictive cardiomyopathy. We call that secondary. But one of the most common cause for restrictive cardiomyopathy is what we call amyloidosis. The heart muscle becomes infiltrated with amyloid. It's not really primary because the amyloid is usually somewhere else. It usually starts somewhere else and then infiltrate the heart muscle. But these are some of the primary causes of restrictive cardiomyopathy. That is, it develops in the heart muscle itself, the so-called Loeffler's endocarditis and or endocardial fibroelastosis. Okay, and then these are the secondary causes. Cardiac amyloidosis, one of the most common cause of restrictive cardiomyopathy. So you have amyloid elsewhere in the body, and then it infiltrates the heart muscle, causes the heart muscle to be rigid. Hemochromatosis, which is iron overload. So iron overload can weaken the heart muscle, give rise to a dilated cardiomyopathy, or it may infiltrate the heart muscle, giving rise to a restrictive cardiomyopathy. Sarcoidosis can also cause both. Radiation therapy, you can get post-radiation fibrosis, where the heart muscle become fibrotic and rigid. And then carcinoid, scleroderma, Fabry's disease, pseudoxanthoma elasticum. These are some secondary causes. But the thing you need to know is the cardiac amyloidosis, which commonly cause it. So, you evaluate these patients just as you evaluate any other patient. Your 2D echo, you have to look at the LV, you look at the systolic function, of course, diastolic function, you look at the LV dimension, the other chambers, the wall thickness. You tend to get biatrial enlargement. Both atria tend to be enlarged. And this is like a classic feature of a restrictive cardiomyopathy. You usually don't get this significant amount of thickening though, but you tend to get a little bit of pericardial effusion. The atria tend to be huge, but you usually don't get this amount of thickening. So these patients commonly have diastolic dysfunction. So when you do your tissue Doppler imaging, your mitral inflow, they will have some evidence of diastolic dysfunction. They may even present with restrictive physiology, your E to A ratio greater than 2. When you look at your pulmonary vein flow, a very small systolic component and a larger diastolic component. And when you look at your atrial flow reversal, you're going to get increased velocity and duration. So when you look at your pulmonary vein flow, your systolic component is going to be less than your diastolic component. And then the atrial reversal component, increased velocity and duration. Again, your hepatic vein flow, you'll have increased diastolic flow reversal in inspiration. You're going to get increased diastolic flow reversal in inspiration, as opposed to constrictive pericarditis, where you get increased diastolic flow reversal in expiration. We'll go over that, don't worry about that. And then when you look at your tissue Doppler imaging, it's a heart muscle disease, so your E prime is going to be reduced. So in most exams, they want you to distinguish between what they call constrictive pericarditis and restrictive cardiomyopathy. So the mitral inflow might vary. You might have restrictive physiology here, not so much here. Your mitral annular velocity, this is one of the distinguishing features. Your tissue Doppler imaging or your mitral annular velocity, because your restrictive cardiomyopathy is a heart muscle disease, your E prime is going to be reduced. Constrictive pericarditis is a pericardial disease, so the E prime is not going to be reduced because it is not a heart muscle disease, it's a pericardial disease. So E prime going to be normal or sometimes it's exaggerated. And then when you look at your hepatic vein flow, in expiration for constrictive pericarditis, you're going to get your increase, your atrial flow reversal is going to be increase in expiration. You get increase in your atrial flow reversal in expiration. Whereas restrictive cardiomyopathy, the increase in your atrial flow reversal is with inspiration. We'll go over that, okay? But that's a very important feature. So in expiration, so this is what we call a rest parameter. And you have inspiration, expiration, inspiration, expiration. So what we're saying in constrictive pericarditis, in expiration, you get an increase in your atrial flow reversal. And then for restrictive cardiomyopathy, the increase is with inspiration. The increase is with, one second, let's get back to that. So with restrictive cardiomyopathy, with inspiration, that's when you tend to get your increase in your atrial flow reversal. All right, so that's restrictive cardiomyopathy. Again, with inspiration, you get your increase in your atrial flow reversal. All right. Um, so we're going to stop here. Then the next topic is arrhythmogenic right ventricular hypertrophy, but we're going to stop here. And